So, a 25-year-old female presents with generalized restriction of eye movements in all the directions, intermittent ptosis, proximal muscle weakness, and fatigability, which is the most useful test in making the diagnosis. The correct answer is hydrophonium test. So, the patient mentioned in the question, is showing signs and symptoms of myasthenia gravis. So here hydrophonium test is the most useful test in making diagnosis of this condition because of the rapid onset and short duration of this effect. So this test is considered to be positive if there is any improvement in the weakness of this patient after administration of hydrophonium. So other diagnostic tests used for diagnosing myasthenia gravis include acetylcholine receptor antibodies and rapid nerve stimulation test. So presence of the acetylcholine receptor antibodies is virtually diagnostic of myasthenia gravis, but a negative test does not exclude the disease. And then rapid nerve stimulation test, the electric shocks are delivered at a rate of 2 to 3 per second to the appropriate nerves, and action potentials recorded from the muscles. In these patients, there is rapid reduction of more than 10 to 15% in the amplitude of the evoked responses. The next question is, Kayser-Fleischer rings, that is KF rings, are seen in? The correct answer is Wilson's disease. The next question, all of features of A beta lipoproteinemia except the correct answer is option D, that is neurological manifestation as ataxia in the first decade. So here plasma levels of cholesterol and triglyceride are extremely low in this disorder, and also chylomicrons are also low. So A beta lipoproteinemia usually presents in early childhood with diarrhea and failure to thrive. The neurological manifestations like decreased distal lower extremity vibratory and proprioceptive sense, dysmetria, ataxia, and development of spastic gait often by the third or fourth decade. The patients will also develop a progressive pigmented retinopathy presenting with decreased night and color vision. So the next question is, which of the following findings is diagnostic of iron deficiency anemia? The correct answer is option A, that is increased TIBC and decreased serum ferritin. So iron deficiency anemia is associated with increased total iron binding capacity, that is TIBC, and decreased serum ferritin. Ferritin is the storage form of iron. The next question is, which of the following endocrine tumors is most commonly seen in men 1? The correct answer is gastronoma. So amongst these four options, that is insulinoma, gastrinoma, glucagonoma, somatostatinoma, gastrinomas are the most common enteropancreatic tumors associated with men 1, with insulinomas being the second most common. The next question is, all of the following statements regarding sickle cell anemia are true except the correct answer is patient usually presents before the age of 6 months. So sickle cell anemia is an autosomal recessive disorder which is caused by an amino acid substitution of valine for glutamine in the 6th position on the beta globin chain. So onset of the sickle cell anemia starts during the first year of life, especially after 6 months of age, when hemoglobin F HbF levels fall, as a signal is sent to switch from production of gamma globin to beta globin. And then hemoglobin S is unstable and polymerizes during hypoxemia and acidosis, leading to sickling of RBCs. So patient will develop jaundice, pigmented gallstones, splenomegaly, poorly healing ulcers over the lower tibia. Acute painful episodes can occur due to acute vaso-occlusion by clusters of sickled red blood cells during infection, dehydration, or hypoxia. Common signs of acute painful episodes include bones and the chest. The next question is, leukoerythroblastic picture may be seen in all of the following conditions except the correct answer is thalassemia. So leukoerythroblastosis refers to the presence of immature nucleated RBCs, immature WBCs, and megakaryocyte fragments on the peripheral blood smear. It can occur due to bone marrow infiltration. When the marrow infiltration causes anemia or pancytopenia, it is referred to as myelophthisic anemia. So the most common cause of myelophthisia includes metastatic carcinoma of the lung, breast, or prostate. The other causes include hematologic malignancies like leukemia, lymphoma, infections like tuberculosis or fungal infections, metabolic diseases like Gaucher's disease, Niemann-Pick disease. Thalassemia is not associated with leukoerythroblastosis. So the next question is, all of the following are major complications of massive transfusion except the correct answer is option A, that is hypokalemia. So complications with massive blood transfusion include hyperkalemia, hypocalcemia, hypomagnesemia, hyperammonemia, hypothermia, acidosis, dilutional coagulopathies, and DIC and ARDS. DIC is disseminated intravascular coagulation, which is the most worrisome problem after massive transfusion, and it is the usual cause of death after massive blood transfusion. So the lethal triad of acidosis, hypothermia, and coagulopathy associated with massive blood transfusion has a high mortality rate. The next question is, Richter syndrome refers to which of the following malignant transformation? The correct answer is CLL evolving into aggressive lymphoma. So here, Richter's transformation or Richter's syndrome is a complication of B-cell chronic lymphocytic leukemia or hairy cell leukemia, in which the leukemia changes into a fast-growing diffuse large B-cell lymphoma. The next question is, sickle cell anemia leads to resistance towards. The correct answer is Plasmodium falciparum. So individuals with sickle cell trait, hemoglobin genotype AS, are resistant to the lethal effects of Plasmodium falciparum infection. This is because the sickle cell traits prevent the development of hyperparasitemia, probably partly as a result of parasitized RBC sickling in the circulation and being removed by the spleen before they can develop into schizones. Absence of RBC Duffy antigen confers resistance to Plasmodium vivax. So the next question is, romiplastim acts on which of the following receptors? The correct answer is thrombopoietin receptor. So romiplastim is a genetically engineered protein in which the Fc component of a human antibody is fused to 2 copies of a peptide that stimulates the thrombopoietin receptors. This romiplastim is approved for the treatment of ITP, idiopathic thrombocytopenic purpura. The next question is, oncogene associated with Burkitt's lymphoma. The correct answer is c-Myc oncogene. So oncogene with mantle cell lymphoma is BCL1 IgH, follicular lymphoma BCL2 IgH, diffuse large B cell lymphoma the oncogene will be BCL6 P53. For Burkitt's lymphoma and Burkitt's leukemia, oncogene associated will be c-Myc. CD30 plus anaplastic large cell lymphoma, the oncogene will be ALK. Lymphoplasmacytoid lymphoma, the oncogene will be PAX5 and IgH. The next question is, false statement regarding ECG in acute pericarditis. The correct answer is T-wave invasion develop after ST elevations return to the baseline. So here the T-wave invasion will develop after ST elevations return to the baseline. There are 4 stages of ECG changes in the evolution of acute pericarditis. So in stage 1, there is widespread elevation of the ST segments, often with upward concavity, involving 2 or 3 standard limb bleeds, and V2 to V6 with reciprocal depressions only in AVR and sometimes V1, as well as depression of the PR segment. Usually there are no changes significant in the QRS complexes. In stage 2, after several days, the ST segments return to normal, and only then or even later do the T waves become inverted, which is the stage 3. Ultimately, weeks or months after the onset of acute pericarditis, the ECG returns to normal in stage 4. Omalizumab is used in the treatment of. The correct answer is asthma. Omalizumab is a blocking antibody that neutralizes circulating IgE without binding to cell-bound IgE. So thus it inhibits the IgE mediated reactions. So this omalizumab treatment has shown to reduce the number of exacerbations in patients with severe asthma and may improve asthma control. However, the treatment is very expensive and only suitable for highly selected patients who are not controlled on maximal doses of inhaler therapy and have a circulating IgE within a specified range. The next question will be, the pathognomonic finding in miliary TB is which of the following? The correct answer is option B, that is choroid tubercles. Eye examination in case of miliary TB will reveal choroidal tubercles, which are pathognomonic of miliary TB, and it is seen in up to 30% of the cases. Next question, all are important pathogens causing pneumonia in COPD patients except. The correct answer is Klebsiella pneumoniae. So important pathogens causing pneumonia in COPD patients include Haemophilus influenzae, Pseudomonas aeruginosa, Legionella species, Streptococcus pneumoniae, Moraxella catarrhalis, Chlamydia pneumoniae, Klebsiella. So Klebsiella is an important pathogen causing pneumonia and chronic alcoholism. The next question is PNH patients will be having deficient surface proteins that normally protect the red cells from activated complements. So, what are the two deficient surface proteins? The correct answer will be option C, that is CD55 and CD59. So, the definitive diagnosis of paroxysmal nocturnal hemoglobinuria, that is PNH, is based on the demonstration that a substantial proportion of the patient's RBCs have an increased susceptibility to the complement C due to the deficiency on the surface proteins, particularly CD59 and CD55. The next question is, which of the following biochemical test is used to diagnose Dubin-Johnson syndrome? The correct answer is option B, that is bromosulfine test. So here bromosulfine test is the diagnostic test for Dubin-Johnson syndrome. Biliary excretion of numerous anionic compounds like bromosulfine is compromised in Dubin-Johnson syndrome. So here in this bromosulfine test, bromosulfine is administered as IV bolus and its clearance from the plasma is determined. Bromosulfine levels show a characteristic rise in patients with Dubin-Johnson syndrome after 90 minutes of injection due to reflux of conjugated bromosulfine into the circulation from the hepatocyte. The next question is, cholecystokinin is produced from, the correct answer is option C, that is duodenal mucosa. So the major factor controlling the contraction of gallbladder is the hormone cholecystokinin, which is released from duodenal mucosa, that is eye cells, in response to the ingestion of fats and amino acids. The next question is, esophageal manometry is useful in all the conditions except, the correct answer is malignancy. So esophageal manometry or motility testing entails positioning a pressure sensing catheter within the esophagus. Manometry is used to diagnose motility disorders like echalalia, diffuse esophageal spasm, and to assess the peristaltic integrity prior to surgery for reflux disease. Esophageal malignancy is not diagnosed with esophageal manometry. Upper GI endoscopy is the effective method for malignancy and biopsy can be taken. The next question is, which of the following drugs is useful in the prophylaxis of migraine? The correct answer is propranolol. So drugs such as topiramate, valproate, propranolol, timolol, candesartan, verapamil and amitriptyline are indicated in migraine prophylaxis. So migraine prophylaxis is indicated when migraine headaches occur more than 2 or 3 times a month or when it is associated with significant disability. So after initiation of the therapy, it should be continued for several months. So once the patient remains headache free, the dose is tapered and the drug is eventually withdrawn. Botulinum toxin type A was approved by US Food and Drug Administration for migraine prevention in the late 2010s. The next question is, all of the following are true about treatment of migraine except, the correct answer is sumatriptan is used for chronic migraine. So sumatriptan is an agonist at 5-HT serotonin receptors, particularly 5-HT1B1D receptors. It is used in the treatment of acute migraine attacks but not recommended for migraine prophylaxis. The drug provides rapid relief of migraine headache as well as relief of the associated manifestations of migraine causing including nausea, vomiting, photophobia and phonophobia. So short-acting, rapidly effective triptans include almotriptan, sumatriptan, rizatriptan, zolmitriptan, elatriptan, whereas naratriptan and provatriptan have the longest half-lives. 5-HT1B1D receptor agonist are sumatriptan, naratriptan, rizatriptan, zolmitriptan. The next question is, lateral medullary syndrome is due to occlusion of which of the following vessels? The correct answer is vertebral artery. So lateral medullary syndrome is otherwise known as Wallenbach syndrome or PICA syndrome or vertebral artery syndrome. PICA means posterior inferior cerebellar artery. So lateral medullary syndrome, the most common cause of lateral medullary syndrome will be occlusive disease of the intracranial segment of the vertebral artery. So signs and symptoms of lateral medullary syndrome include, it is almost always ipsilateral. It occurs on the ipsilateral side mostly and associated with the Horner syndrome, decrease in pain and temperature sensation on the ipsilateral side of the face, cerebellar signs, especially ataxia. So these are the ipsilateral signs and symptoms. So in contralateral side, there will be decreased pain and temperature on the contralateral body, dysphagia, dysarthria, hoarseness, paralysis of the vocal cord, vertigo, nausea, vomiting, hiccups, nystagmus, diplopia, and especially in this lateral medullary syndrome, there is no facial or extremity muscle weakness. The next question is, POEM syndrome includes all except the correct answer is option D, that is multiple sclerosis. So, features of POEM syndrome include polyneuropathy, organomegaly, endocrinopathy, multiple myeloma, and skin changes. So, the patients will have a high degree of very severe progressive sensorimotor polyneuropathy associated with sclerotic bone lesions from myeloma. Polyneuropathy occurs in about 1.4% of myelomas, but POEM syndrome is only a rare subset of that group. Unlike typical myeloma, hepatomegaly and lymphadenopathy occur in 2/3 of the patient and splenomegaly in 1/3 of the patients. So next question is, bar body is found in the following phase of the cell cycle. The correct answer is interphase. The inactive X chromosome can be seen in the interphase nucleus as a darkly staining small mass in contact with the nuclear membrane known as the bar body or X chromatin. So bar body is the inactivated X chromosome. In non-dividing interphase cells, it remains tightly coiled and can be seen as dark staining body within the nucleus. The next question is, all of the following statements about pulses bigeminis are true except the correct answer is compensatory pause is absent. So pulses bigeminis is associated with a compensatory pause, but the compensatory pause is absent in pulses alternans. So pulses bigeminis is a disorder of rhythm. It has irregular rhythm caused by a normal beat alternating with a premature contraction and a compensatory pause resulting in alternation of the strength of the pulse. So the stroke volume of the premature beat is diminished in relation to that of the normal beats, and the pulse varies in amplitude accordingly. Pulses bigeminis most commonly mimics pulses alternans, from which it must be distinguished. In pulses alternans, the rhythm is regular and compensatory pause is absent. The next question is, pulses bigeminis is seen in therapy with, the correct answer is digitalis therapy. So pulses bigeminis is recognized as a cause of digitalis toxicity, and as we know, pulses bigeminis is a disorder of the rhythm, mostly irregular rhythm arrhythmia, most commonly caused by premature ventricular contractions that results in a pulse with irregular rhythm that alternates in amplitude from beat to beat. The most common cause of pulses bigeminis is digitalis, and pulses bigeminis is recognized as a cause of digitalis toxicity. The next question is, wide pulse pressure is seen in all of the following except the correct answer is aortic stenosis. Aortic stenosis is associated with narrow pulse pressure. Patent ductus arteriosus, aortic regurgitation, and AV malformations or arteriovenous shunting are all associated with a wide pulse pressure. The next question is, Erb's point in cardiology refers to right third intercostal space. In cardiology, Erb's point refers to the third intercostal space on the left sternal border where both components of S2, that is A2 and P2, can be well appreciated. So both components of S2, that is A2 and P2, are well transmitted to the Erb's point. The physiological splitting of S2 into A2 and P2 is believed to be best appreciated at the Erb's point or in the pulmonic area. A2 is best heard over the aortic area in right second intercostal space. P2 is best heard over the pulmonic area in the left second intercostal space. Second heart sound, that is S2, is best heard over the pulmonic area, since both A2 P2 can be heard at pulmonic area, and S2 is also heard at the Erb's point. So even at the pulmonic area, A2 is louder than P2. So aortic area corresponds to the second intercostal space to the right of the sternum along the right upper sternal border. Pulmonic area is in the second intercostal space to the left of sternum along the left upper sternal border. Erb's point is in the third intercostal space to the left of sternum along the left sternal border. Tricuspid area is in the fourth or fifth intercostal space to the left of the sternum along the left lower sternal border. Mitral area apex corresponds to the fifth intercostal space on the left midclavicular line. So the next question will be S2 is best appreciated in. The correct answer is third, left intercostal space. So best areas to auscultate for both components of S2, that is A2 P2, are either left sternal border at the level of second intercostal space, that is pulmonic area, or at the left sternal border at the level of third intercostal space, that is Erb's point. So the second heart sound has two components, that is A2 and P2. A2 results from aortic closure and P2 results from pulmonary closure. So P2 is a soft sound that is poorly transmitted. It is best heard at the pulmonic area and transmitted only as far as the Erb's point. A2 is a loud sound best heard over the aortic area, but since it is widely transmitted, it may be heard across all areas of the chest, even as far as the apex. S2 is best heard over pulmonic area since both A2 and P2 can be heard at the pulmonic area. So even at the pulmonic area, A2 is louder than P2. The other area to auscultate for both components of S2 is at the left sternal border of third intercostal space, that is Erb's point. The next question is paradoxical splitting of the second heart sound is seen in. The correct answer is left bundle branch block, option C, LBB. So left bundle branch block, that is LBB, is associated with reversed or paradoxical splitting of S2. So paradoxical splitting of S2 is caused by delayed A2 or early P2. Left bundle branch block is associated with delayed aortic closure, delayed A2, due to delayed electrical activation of the left ventricle. ASD and right bundle branch block are associated with wide physiological or non-paradoxical split of the S2 due to delayed pulmonary closure, that is delayed P2, while VSD is associated with wide physiological or non-paradoxical split S2 from early aortic closure, that is early A2. The next question will be, all of the following statements about S3 are true except the correct answer is option A, that is it occurs due to rapid filling of the ventricles during atrial systole. So S3 occurs at the end of early rapid filling phase of the ventricle but not at the time of atrial systole. The heart sound associated with ventricular filling during atrial systole is the S4. So S4 occurs in association with an effective atrial contraction. It is presumably caused by inrush of blood into the ventricles when the atria contracts, and hence it is also called as the atrial heart sound. So pathological S3 may be associated with ASD and BSD. A pathological S3 is often present in large left or right shunts due to high flow across the mitral valve with VSD or PDA and with high flow across tricuspid valve with ASD. The presence of this sound in these conditions does not imply congestive heart failure, and such patients may maintain normal myocardial contractility for years after the S3 is detected. So congenital heart diseases which are associated with loud S3 include ventricular septal defect, patent ductus arteriosus, and atrial septal defect. So pathological S3 may be associated with constrictive pericarditis. So constrictive pericarditis is characteristically associated with pericardial knock, which is distinct. This pericardial knock is a distinct form of S3. So pericardial knock is S3 that occurs earlier means 0.1 to 0.12 seconds after A2, and this pericardial knock is high pitched than normal. Its presence depends on the restrictive effects of the adherent pericardium, which halts diastolic filling abruptly. The next question is, left axis deviation is seen as. The correct option is positive in lead 1 and negative in lead 2. So left axis deviation is seen as positive deflection in lead 1 and a negative deflection in lead 2. So in normal axis, lead 1 is positive, lead 2 is positive, lead 3 may be positive or negative. In right axis deviation, lead 1 will be negative, lead 2 will be positive or negative, lead 3 will be positive. In left axis deviation, lead 1 is positive, lead 2 is negative, lead 3 is also negative. So in lead 1 will be positive between minus 90 to plus 90, that is clockwise. Lead 2 will be positive between minus 30 to plus 150 clockwise. Lead 3 will be positive between plus 30 to minus 150, which is also clockwise. The P wave is due to, the correct answer is atrial depolarization. So P wave is produced due to atrial depolarization. So P wave corresponds to atrial depolarization, and the PR interval corresponds to atrial depolarization and conduction through AV node. QRS duration corresponds to ventricular depolarization and atrial repolarization. QT interval corresponds to ventricular depolarization plus ventricular repolarization. ST interval, that is QT minus QRS, corresponds to ventricular repolarization. So the next question is, absent P wave is seen in, the correct answer is atrial fibrillation. So P wave is typically absent in atrial fibrillation. COPD and cor pulmonale are associated with the tall P waves from right atrial enlargement, that is P pulmonale, while mitral stenosis is typically associated with wide and notched P wave from left atrial enlargement, that is P mitral. So causes of absent P wave includes atrial fibrillation, where P wave is absent or replaced by fibrillary T wave; atrial flutter, where P wave is replaced by flutter wave which shows sawtooth appearance; SA block or sinus arrest; nodal rhythm, which is usually abnormal small P wave; ventricular ectopic and ventricular tachycardia; supraventricular tachycardia, which is P wave where P wave is hidden within QRS due to tachycardia; hyperkalemia, and idioventricular rhythm. So idioventricular rhythm means it can be P pulmonale or P mitral. So P pulmonale is where right atrial enlargement is typically associated with tall P waves. COPD and cor pulmonale are associated with tall P waves from right atrial enlargement. P mitral is where left atrial enlargement is typically associated with wide P waves. The mitral stenosis is typically associated with wide and notched P wave from left atrial enlargement. A patient in regular rhythm presents with absent P waves on ECG. Leads 2, 3 and AVF reveal a sawtooth pattern. Which of the following is the most likely diagnosis? The correct answer is option C, that is atrial flutter with fixed block. The absence of any discernible P waves on ECG together with the presence of sawtooth flutter waves in inferior leads, that is leads 2, 3 and AVF, strongly suggests a diagnosis of atrial flutter. The presence of regular rhythm suggests a fixed block. So if there is irregular rhythm with no discernible P wave, that is chaotic baseline with fibrillary F waves, then the diagnosis will be atrial fibrillation. If there is irregular rhythm with no discernible P wave, that is sawtooth flutter waves, especially in the inferior leads and V1, the diagnosis will be atrial flutter with variable block. If there is a regular rhythm with no discernible P waves, that is sawtooth flutter waves, especially in the inferior leads and V1, the diagnosis will be atrial flutter with fixed block. If there is irregular rhythm with multiple P wave morphologies, that is discernible P waves and varying PR intervals, the diagnosis will be multifocal atrial tachycardia. So the next question is, a wide and notched P wave is typically seen in, the correct answer is mitral stenosis. So mitral stenosis is typically associated with a wide and notched P wave from left atrial enlargement, cor pulmonale, COPD, pulmonary embolism. They are all associated with right atrial enlargement, resulting in a tall P wave and not a wide P wave. The next question is, QRS duration between 100 to 120 milliseconds suggests all of the following except the correct answer is left bundle branch block. So left bundle branch block is typically associated with QRS duration greater than 120 milliseconds. Partial block, that is it can be fascicular or hemi blocks. So partial block in the left bundle system, that is left anterior or posterior fascicular blocks, generally do not prolong the QRS duration substantially, and QRS duration typically remains less than 120 milliseconds. The next question is low QRS voltage on ECG with left ventricular hypertrophy and echocardiography suggests a diagnosis of. The correct answer is cardiac amyloidosis. So low QRS voltage on ECG with left ventricular hypertrophy on echocardiography suggests a diagnosis of infiltrative cardiomyopathy like amyloidosis. The combination of low QRS voltage plus a thick left ventricle on echocardiogram strongly suggests the diagnosis of infiltrative cardiomyopathy like cardiac amyloidosis. The increased thickness is the amyloid. It is not that muscle, not true hypertrophy, so does not depolarize and therefore adds nothing to the QRS voltage. The next question is tall T waves on ECG are seen in. The correct answer is hyperkalemia. So hyperkalemia is typically associated with tall peaked narrow based T wave. The next question is ST elevation is seen in all of the following conditions except. The correct answer is option C, that is constrictive pericarditis. So ST segment is measured from the end of QRS complex to the beginning of T wave, and it represents the time interval between ventricular depolarization and repolarization. The next question is the most common re-entrant tachycardia associated with WPW syndrome is, that is Wolff-Parkinson-White syndrome is. The correct answer is option A, that is orthodromic AV re-entry. So the most common macro re-entrant tachycardia associated with WP syndrome is orthodromic AV re-entry. The most common macro re-entrant tachycardia associated with WPW syndrome is referred to as orthodromic AV re-entry. The next question is athletic syndrome is characterized by. The correct answer is increased amplitude of QRS complex. So athletic heart syndrome is a benign condition consisting of physiologic adaptations to the increased cardiac workload of exercise in trained athletes. It represents a constellation of clinical findings that are the result of normal physiologic adaptation to strenuous physical activity. In response to the increased physical demand, left ventricles dilate and wall thickness increases. The mass to volume ratio, however, does not change. So on physical examination, there will be decreased body fat and increased muscle mass, which is generally the patient will be very physically fit, and the pulse will be slow and often irregular, that is sinus bradycardia or bradycardia with first and second degree blocks. Then grade 1 or 2 mid-systolic murmurs, that is benign functional ejection murmur, resolves with Valsalva maneuver. Then S3 and S4 is very common due to they are actually the benign filling sounds. BP typically remains normal. So ECG rhythm will be sinus bradycardia of 40 to 55 beats per minute while at rest. Sinus passes of more than 2.0 seconds due to increased vagal tone. Wandering atrial pacemaker found only in dynamic athletes. First degree AV block present only at rest. PR interval normalizes with exercise. Second degree AV block present only at rest. In second degree there is Mobitz 1 and Mobitz 2. So Mobitz 1 or Wenke-Bach block is common in marathon runners. Mobitz 2 is rare in athlete's heart. So voltage will be TORS voltage, TORS voltage, that is amplitude. So LV hypertrophy is found in 85% of Olympic marathon runners. RV hypertrophy is common in dynamic athletes but rare in sedentary controls and static athletes sedentary control. And then repolarization. Regarding repolarization, there will be ST segment elevation with peaked T waves which normalizes with exertion, and ST segment depression will be rare in athletes. T wave inversion and lateral leads associated with interventricular septal hypertrophy in static athletes, which can be a normal finding in dynamic athletes. So chest X-ray findings, the heart will be globular in appearance, particularly in endurance athletes. Then there will be cardiomegaly where cardiothoracic ratio is more than 0.50. The next question will be predisposing factors for coronary artery disease include all of the following except. The correct answer is increased lipoprotein B. So Predisposing factors for coronary artery disease include increased lipoprotein A and not lipoprotein B. The next question is 40-year-old male patient presents to the emergency department with central chest pain for 2 hours. ECG shows ST segment depression and cardiac troponins are elevated. Patient has positive history of previous percutaneous coronary implant 3 months back. He is administered with aspirin, clopidogrel, nitrates and low molecular weight heparin in the emergency department and shifted to the coronary care unit. The best recommended course of further action should include, the correct answer is early revascularization with percutaneous coronary intervention, PCI. So here the patient is presenting as a case of NSTEMI, that is non-STEMI, to the emergency department. The presence of elevated cardiac troponins and history of previous PCI place the patient into a high risk category. The patient in question is a high risk patient with NSTEMI. So such patients are candidates for early invasive management with PCI or CAPG. So the next question is the most common toxin causing dilated cardiomyopathy. The correct answer is alcohol. So chronic alcohol consumption is the most common cause of toxic dilated cardiomyopathy. Alcohol is the most common toxin which is implicated in chronic dilated cardiomyopathy. So dilated cardiomyopathy is the most common type of cardiomyopathy. The most common cause of dilated cardiomyopathy will be 2/3 due to idiopathic, and alcohol consumption is the most common cause of toxic dilated cardiomyopathy. The next question is the 9-month-old child of a diabetic mother presents with tachypnea and hepatomegaly. Echocardiography of the heart showed normal cardiac morphology with asymmetric septal hypertrophy. So which of the following you will give to treat this child? The correct answer is option C, that is propranolol. So symptoms of the patient: an echocardiographic finding of asymmetrical septal hypertrophy almost confirms the diagnosis of hypertrophic cardiomyopathy. Beta blockers should be the initial drug in symptomatic individuals. Management of HOCM includes avoidance of strenuous physical activity. Beta blockers should be the initial drug in symptomatic individuals. So beta blockers will reduce heart rate, BP, stiffness of left ventricle, fatal arrhythmias. And then calcium blockers, that is verapamil and diltiazem, are the alternative drugs. They reduce the stiffness of the ventricles and elevated diastolic pressures. Amiodarone may be used to reduce arrhythmias, and surgical myomectomy can also be done. The next question is Kussmaul's sign is classically described in, the correct answer is constrictive pericarditis. So Kussmaul's sign is classically described in association with constrictive pericarditis. Kussmaul's sign refers to paradoxical elevation of JVP or central venous pressure during inspiration. In healthy persons, venous pressure falls during inspiration because pressures in the right heart decrease as intrathoracic pressures fall. The Kussmaul sign is classically described in association with constrictive pericarditis. Kussmaul sign is, however, also seen in association with RV infarction, restrictive cardiomyopathy, pulmonary embolism, and advanced systolic severe heart failure. The next question is hypertension with hypokalemia is seen in, the correct answer is Liddle syndrome. So Liddle syndrome is typically associated with hypokalemia and hypertension. Rarter syndrome and Gittelman syndrome are also associated with hypokalemia but without hypertension. And so regarding Liddle syndrome, the pathophysiology will be, it is an autosomal dominant disorder. It occurs due to genetic defect in the collecting tubule sodium channel, resulting in inhibition of high levels of intracellular sodium. The age of presentation of this Liddle syndrome will be, it is actually diagnosed at an young age, but it can present in adulthood also. Due to phenotypic variation. So the clinical presentation will be, it presents with a classic triad of hypertension, metabolic alkalosis and hypokalemia. So consider the family history of hypertension, hypokalemia, and lab data will reveal metabolic alkalosis, hypokalemia, low urinary output. And treatment for this Liddle syndrome will be lifelong treatment. So potassium channel diuretic can be used for treatment. It closes the sodium channels. Spironolactone will not work in case of Liddle syndrome because aldosterone is not causing the symptoms. So the next question is, which of the following statements about atrial myxomas is true? The correct answer is it is most common in left atrium. So cardiac myxomas are commonly located in the atria and it is more common in the left. So cardiac myxomas are the most common type of primary cardiac tumors. It occurs at all ages and it shows no sex preference. It mixes equally with both sexes. So most cardiac myxomas are sporadic while some may be familial also. So sporadic myxomas are solitary. It is located in atria, most commonly in the left, and unlikely to have post-op recurrence, occurs in younger individuals. So familial myxomas are multiple, more likely to have post-op recurrence. Myxomas are benign tumors and therefore distant metastasis is not seen. So the next question will be, which condition is most commonly associated with coarctation of aorta? The correct answer is bicuspid aortic valve. So the most common associated cardiac anomaly with coarctation of aorta is bicuspid aortic valve. Coarctation of aorta is associated with bicuspid aortic valve in more than 70% cases. So bicuspid in coarctation of aorta, the anomalies associated will be bicuspid aortic valve, which is the most commonest, followed by PDA, VSD, tubular hypoplasia of the aortic arch, aortic stenosis. So the Schoen complex, SHONE, Schoen complex includes coarctation of aorta, left-sided obstructive lesions, which include mitral valve abnormalities and subaortic stenosis. So mitral valve abnormalities include subvalvular mitral ring or parachute mitral valve, and then Turner syndrome. The next question is, acute infective endocarditis with abscess formation is most commonly associated with? The correct answer is staphylococcus. So acute infective endocarditis with abscess formation is most commonly associated with staphylococcus. The most common organism causing acute infective endocarditis overall is Staph aureus. So Staph aureus endocarditis is particularly virulent and associated with annular and myocardial abscess formation and high mortality. So the next question is, in Marfan syndrome, aortic aneurysm occurs most commonly in? The correct answer is ascending aorta. So aortic aneurysms in Marfan syndrome occur most frequently in ascending aorta. So cardiovascular lesions in Marfan syndrome include, actually the cardiovascular lesions are the most life-threatening features of Marfan syndrome. So in mitral valve prolapse, there is loss of connective tissue support in mitral valve leaflets, which makes them soft and blowy, creating the so-called floppy valve. So eventually mitral regurgitation will result. So dilatation of ascending aorta. So cardiovascular lesions in Marfan syndrome include mitral valve prolapse and dilatation of ascending aorta. So in dilatation of the ascending aorta, the media undergoes cystic necrosis, that is cystic medianecrosis. Loss of medial support results in progressive dilatation of the aortic valve ring and root of the aorta, and there will be severe aortic incompetence and aortic dissection. The next question is, which of the following is not expected in a case of microcytic hypochromic anemia? The correct answer is option B, that is reduced total RBC distribution width. So microcytic hypochromic anemias are typically associated with a normal or high red cell distribution width.